I think what's really exciting about liver cancer as a disease is it's one of the few diseases that we know the cause, which is cirrhosis. Given there's a variety of causes of cirrhosis, we know who's at risk, which gives us a huge opportunity to intervene early, potentially. And Dr. Vogel, could you comment about how we should try to find liver cancer early?
Yes, I think you're right, but it's not completely right, because as you have just mentioned before, we have a shift in the underlying cause of liver cancer. So we were used that most patients have a viral hepatitis, and most of these patients, specifically with hepatitis C, have liver cirrhosis once they develop HCC. In hepatitis B, we have also seen that some of these patients have HCC in a non-cirrhotic liver, which makes it already a little bit more difficult. And specifically in fatty liver and NAFLD, NASH, we see more and more patients that do not really have a chronic history of liver disease, which makes it more difficult to apply screening programs. So in high-risk groups, we would generally recommend to do screening. Screening would include ultrasound and some testing of tumor markers like AFP, which also is not perfect. Specifically, AFP has a low sensitivity, so we might miss a lot of patients that do have tumors without AFP, so we would not see them if we would just rely on AFP testing. And on the other hand, if we do ultrasound as a screening method, it depends on the physician who's doing the ultrasound and also the equipment he has to do the ultrasound. So in general, ultrasound is a good tool to detect liver nodules. But if we have now a shift from viral hepatitis, liver cirrhosis, to fatty liver disease, it's getting more complicated, because in patients that have obesity and have a fatty liver, detecting nodules is far more difficult than in patients without fatty liver. And the other point is not only it's getting more difficult, we are getting also more patients that are potentially at risk. On the one hand, we have to acknowledge that of course not all patients with fatty liver get liver cancer, but they are at risk. So we would have to screen a lot of not really patients, but people with fatty liver that are at risk to develop liver cancer.
So I think what you're saying confirms a lot of what is in guidelines. Is you can't rely on a blood test alone. Imaging is really the standard. Ultrasound has limitations. If you want to check AFP, that is okay, but you can't rely solely on AFP. Are there other serum markers that people are looking at now?
I mean, there are more serum markers that are in development, I would say, and we have some retrospective data that indicate that we will detect more patients. So that are biomarkers like AFP-L3 and PIVCAR-DCP. So if we combine them, and if you also include gender and age, we have a higher, we might develop scores which indicate who has a higher risk to develop cancer. And maybe this could be a method to really do some kind of pre-screening based on lab tests, and those patients that have an increase in their scores would then refer to more regular screening by ultrasound or even MRI if there's a strong increase in their scores of these based on these biomarkers. So I think this will be probably in the future the way we have to go, that we really have to combine and different markers and then identify those patients that really require good imaging.
So I think, though, we can say pretty certainly there is a group that definitely needs screening, and those are probably patients who have known cirrhosis,
yes,
known hepatitis, and importantly, you can only find cirrhosis if you look for liver disease, and,
yes,
and there's probably a big under-awareness of that in the community.
Of course, and we have to acknowledge that patients that have chronic liver diseases do not really know that they have underlying liver diseases. If they have hepatitis C or B without any symptoms of advanced liver disease, they might not even know that they have a liver disease,
right,
which is specifically tragic if you think about hepatitis C. So we have now very effective treatments available for hepatitis C, but the people need to know that they have a disease
Sure,
which can be cured.
Sure.
Could I make a comment about the value and efficacy of tumor marker screening? Because the endpoint of screening is to detect the disease at an early stage that the patients may benefit from treatment and have an improved survival. We all know that AFP and all the tumor markers increase and are a reflection of a more advanced or more aggressive stage. So in a way, the detection through tumor markers by default is going to detect tumors that are more advanced, that are more aggressive, and in whom the patients will not really benefit potentially from the detection and from the treatment because they will be more advanced. So
we don't know, but I mean, we
now
could
it's in the when you do the modelings of what is the outcome going to be, this is one of the important considerations.
Of course.
The goal is to detect the disease when it is less than 2 centimeters in size, no tumor markers, no symptoms, no vascular invasion. And AFP and all the other markers have always been associated to a higher rate of microscopic vascular invasion. So when you have positive results, you have a dismal or less optimistic outcome.
I think it's been one of the limitations of the current studies that where they use as their outcome HCC at any stage, whereas really the outcome for these biomarker studies has to be HCC at an early stage, if not at a very early stage, as you said. I think that you're right that all of these biomarkers perform much better when they're at an advanced stage. We're hoping that some of these biomarkers will be able to perform, particularly when you use it as a panel, at least reasonably well at an early stage. I think that given the heterogeneity of HCC, I think it's going to have to be multiple biomarkers. I don't think any single biomarker is going to work in isolation. But I think that Dr. Vogel brings up a very important point that all of the old ultrasound studies were primarily conducted in a viral hepatitis patient population and had significant limitations in terms of the patient population. These were often very lean individuals, more oversampling of hepatitis B where ultrasound performs better. There have been several studies that show that ultrasound, even outside of its operator dependency, works much worse in patients with non-alcoholic steatohepatitis. And so I think biomarkers, are going to be the future. And I think that's going to be one of the biggest things that we have to do is find accurate biomarkers for detection at an early stage if we want to have a chance to do well with this cancer.
It's an area that needs lots of research because it's an unmet need to have a biomarker that detects the disease at an early stage.
Agreed.
Because at the same time, AFP, as I mentioned, is a predictor of poorer prognosis. So in a way, always gets redundant in the same direction. We need something better than AFP, and the fact that ultrasound may be difficult does not make the other tools that you may consider adequate.
But let me make one point. Maybe it's better late diagnosis than to have a diagnosis too late. So it's always the question, is the glass half full or empty? And I think in colorectal cancer, we have recommended for a long time blood testing in this tool, which is also a very insensitive method, but still it helped to decrease the incidence and mortality of colorectal cancer. So I would really not discourage the use of screening tools in HCC. And even I completely agree that AFP is not good. I think we still can and should use it.